Okay, so just like Zach talked about, the VFit, the Victory Fitness people, they're going to look at range of motion. They're going to look at effusion. That means if there's any swelling in the knee, our knees normally produce fluid, but when they get inflamed, they produce more fluid than they should, and they swell up, and that means they're not happy. So if they're not puffy, etc., that means your knee's happy. So we look at that. We look at your thigh circumferences. We want them to be very similar. So when we first do that, you can obviously see her grin and Barrett's bear tattoo. We go 10 centimeters above the top of the kneecap here, the patella. And then I'm going to measure the thigh circumferences here. And we'd like them to be within a centimeter. So I am getting 50 centimeters, which we'll check to see if that's improved. I'm sure it has since last time. Look at that, 50.5, so only a half centimeter off. So to me, that is good. She has good thigh bulk. It's not just her quad, it's her whole thigh. Tighten that up real tight, tighten this up real tight. Great tone. Her VMO has come back nicely. As a matter of fact, it looks even a little bigger on the surgical side than the other side. And that's where Zach was talking about, hey, we don't want to neglect the other leg. We don't want to neglect the whole body. And so now how do I test for if there's excess fluid or fluid? Normally there should be like an indentation right here on either side of kind of where the kneecap is here in the side of the knee. And you know, I'll push back and forth. There's really no fluid, excess fluid in this knee, as there shouldn't be because it's your good knee, but sometimes we can overstress that knee and it can swell up as well. And then I look at this knee and I'm seeing absolutely nothing. So no excess swelling, which means your knee's happy. That's a really good thing. Another thing I look at is, if you recall, these incisions initially are kind of reddish, right? And then they turn kind of pinkish and then they turn whitish. And that's basically scar tissue, and that's called maturing and remodeling of your scar tissue. Well, think of those as little windows to the inside of your knee. If the scars on the outside are still pink or red, well, that means the ACL and everything on the healing on the inside is still a little pink or red. It's still not mature yet. Now that these have turned white, and maybe there's a tiny bit of pinkish there, they still could mature, because I mean, that ACL is probably going to mature for a full 2 years or remodel, but they're pretty white. So that also tells me, hey, inside is probably maturing and remodeling as well. If those were still really pink, then I'd be like, hey, maybe we, you know, if everything looks great, we still might want to go a little slower. But no, that looks good as well. Range of motion, what we'll do is I like to have them on a bolster here so we can really see how much hyperextension they have, meaning going past fully straight. And so push that kneecap in as far as you can go. And so I'm getting, I mean, just her doing that is 10 degrees of hyperextension right here. And if I even push it a little further, you know, I can get her to 15. And then bend that knee as far as you can bend it up. So just her doing it on her own is 136, and then me pushing it, I mean, you can get her to 145. So try to hold it there if you can. Yeah, I mean, with me helping her a little bit, she's to 140. So we'll say 140, and then I can get her to 145. No pain, nothing, feels good. She also, not only did she have the Bear Bridge Enhanced ACL Restoration, but she also had a medial meniscus repair, which we can check that out in a minute here as well. All right, push that in as far as you can. You always want to compare both sides. So that starts out maybe a little bit more, like 12, and then I can also push that one to 15. And then bend that up as far as you can. I'm lining this up with her greater trochanter and with her lateral malleolus, the outer side of her ankle. That's 140 right on the dot. And if I push her, I can get her to 145. So I'd say those ranges of motion are essentially equal, which is great. So she's got her range of motion back. Her thigh circumferences are pretty equal. She doesn't have any excessive swelling. She has mature looking scar tissue. So now what other tests can we do? Well, first of all, we're gonna poke around, just see if there's any tenderness anywhere. And so I just start on the inner side here, the medial side, and there's the hamstrings attached here. There's a little bursa here. Tell me if it hurts anywhere. There's a little indentation here. That's where the joint line is, the medial joint line. So I'm gonna press on that. That's where the medial meniscus is. You know, the hamstrings are back here, the gastroc, the calf muscle here. The fat pad is right here. We all have a fat pad under our kneecap that cushions it, under our kneecap tendon as well, that gives blood supply. Sometimes that can be swollen or tender to touch. We press on the thigh bone. The MCL, the medial collateral ligament, attaches right here and all the way down here. I mean, we don't expect any tenderness on her, but I like to poke around. And then the same thing on the other side. I'll poke around on the joint line. I'll feel her lateral collateral ligament, LCL, which feels kind of like a rope. I'll feel on the thigh bone, the shin bone, where the iliotibial band, which is a band of tissue, comes across here, right across here. Sometimes people will have pain, on the tibial tubercle where the kneecap tendon, the patellar tendon attaches right on the actual tendon itself. Some people have tenderness where it attaches to the kneecap or right in it. That would be patellar tendonitis. We're on the patella itself, on the quad tendon. Any tenderness anywhere, even in the back here. Some people have what we call a Baker cyst. Now, while she's here, you can test a posterior drawer, and so the tibia, the shin bone, should be forward on the thigh bone, and when we push back, it really shouldn't have more than a few millimeters of laxity. So the tibia is easily forward on the thigh bone or on the femur, and so that PCL, posterior cruciate ligament, feels fine. We will test the MCL, the medial collateral ligament. So in extension, the casing or the capsule in the back of the knee and the ACL is a bit more taut. So you're really not just testing the MCL by itself, but you get a little bit of a test here, what we call valgus testing. But when you put it at 30 degrees, that relaxes the posterior capsule, the ACL a bit, and there's really no laxity there. But if someone has an MCL sprain, a tear of that ligament there, you'll notice looseness here for sure. And if you notice looseness here too, then it's probably closer to a full tear. Same thing with the LCL, 0 and 30 degrees. And there is usually a little more laxity of the lateral side, the outer side, than the inner side normally. That's pretty normal. We already did the post, so we've tested 3 out of the 4 ligaments now. The granddaddy of them all, the ACL. So I like to just kind of like roll that light, let her get nice and relaxed here. And I'm holding steady on the femur here, the thigh bone. And we call this a Lachman, usually 20 or 30 degrees, and you're just gonna quickly pull forward with the right hand on the opposite side with the other thing. So now there is some excursion here. So she's a little bit loose jointed. We know that from her kneecaps, etc. Loose jointed people are better athletes, but a little bit more prone to injury. Hence, wanting to make sure all your mechanics are good, your muscles, there's no imbalances, all those things Zach talked about. But I'd say she has a 1+ a Lachman, but with a great endpoint. And then to do a pivot shift test, which is a rotational test. The ACL prevents the shin bone from sliding forward on the thigh bone, so it prevents this from sliding forward, but more importantly, it prevents rotation. So when you turn and pivot to the opposite side, it prevents your knee from giving out. So I'm gonna internally rotate to put a little stress on that. I'm gonna put what we call a little valgus stress on here. I'm gonna bring this leg up, kind of bring it down. She's kind of helping me, but if she relaxes there, but I'm not really noticing any clunk or click or anything. So I would say a negative pivot shift test. And then other things we've already noticed on her patella, her kneecap tends to track out to the side. So all the more reason to strengthen these muscles, work on her mechanics, her hips, her all the stuff that Zach talked about. She has a little lateral patellar tilt here. Sometimes people will have what we call a plica. There's a little band of tissue you can kind of feel snapping here. Some people will have chondromalacia of their patella, meaning softening of the cartilage under the kneecap. They'll have tenderness on either side here. If it's unstable, it would pop. It might pop out. You'd have maybe a little bit of looseness. You're kind of loose jointed, but that's just the way you are. You never had any issues with your kneecaps or anything like that, right? Good. Now we're gonna look at this side. So similarly, I'll start on the outer side this time, kind of pressing on the joint line, the lateral collateral ligament, the LCL, the thigh bone, shin bone, where your IT band attaches, your hamstrings back here. And actually, let's look here, because this is where we did the meniscus repair on the medial side. So you tell me if there's any tenderness here. We'll start kind of on the tibia, the shin bone, the bursa, the hamstring attachments. So that's actually on the bone right there. We'll check on your MRI. Some people still have a little reaction in the bone because their knee is weak. It could also be a little bit of bursitis, but that's a little high for where we would see that. But that's kind of right on the bone, not even on our joint line yet. Now, is there any tenderness on this bone right here? Any tenderness along here? And that is the joint line right there where her meniscus would be. So she's got a little bit of tenderness on her proximal medial tibial plateau. Anything on these hamstrings? Okay, so they've been working, you just started doing jumping and stuff like that, right? So you might just be getting a little stress on the bone there. That happens, it's not uncommon. And any tenderness on these incisions here? Any numbness here?
No.
So there's a skin nerve that comes right across here called the infrapatellar branch of the saphenous nerve. Anytime we make an ACL incision or a knee replacement incision or any incisions in the front of the knee, sometimes that can be disrupted and you'll get numbness here, but you have none?
I had some here right after surgery, but it's gone away.
Gone. Yeah. So luckily that's all good. Sometimes that's from swelling, sometimes that just can be from the nerve being retracted out of the way. It's a very small skin nerve. And so again, pressing on the actual patellar tendon. Now, if we did an ACL reconstruction, this would be, and we took a graft from the patellar tendon area, some people will have some tenderness on here. That's one nice advantage of the Bear. We didn't harvest anything from anywhere. We repaired your own ACL and pushed an implant in here, sewed it in between the two ends, and it's healed back together. And so any tenderness on your quad. So sometimes these will get inflamed and get some tendonitis. Itis means inflammation from the rehab, etc. And then that's where Zach's job is to speed it up, slow it down, speed it up, slow it down, which I'm sure you've had a lot of speed it up, slow it down, right? Okay, so really no tenderness. We got our posterior drawer, feels great, which we expect. MCL, a little bit of, same as the other side, a little bit of laxity there, which is her normal state. Just compare the two sides to each other. Same thing, about a 1+ with a great endpoint here, so very similar to the other side. And then I would say 0, no, there's no pivot shift here, there's no clunk, there's no click, there's nothing. And so that's really good. Now, tighten that muscle up real tight, lift this leg up if it's strong. So we're just gonna test out kind of like her hip flexors, also that's her extensors. Here, if you just want to isolate the hip flexors, lift that leg up. So if we were gonna test, what's it?
McMurray.
That will be at the end because we don't, that's where your meniscus is, but yes, thank you. Lift this leg up right here. So this would be testing the hip flexor, and right after surgery, we don't want to be pushing on your shin bone. So, but go ahead and lift it up here, do that as well. And then bend your knee, pull in your hamstrings, push out your quads, pull in hamstrings, push out quads. Point your toes to your nose, toes and ankles up toward your head. So we have Centuri, HL, push down, gastrocnemius, push out, push in, push out again. So they've been working on those your hips too, right? Which actually feel pretty strong there. All right, so what Allison was just talking about was, we'll do the other side first actually, just for comparison. But so when we take your knee up like this and we push these two bones kind of together, when we twist and turn, we're kind of twisting your meniscus between these two bones here, and if there's a problem with it, usually you'll have some pain. And then a lateral McMurray, we're gonna kind of bring the leg out this way, push these two bones against each other, and then just kind of twist or turn and see if anything happens. Any pain? Get some noise in your ankle other than that. And then the same thing here. I'm gonna have my fingers on the joint line here. Any pain twisting or turning that? Nothing. Okay, also when I'm doing this, I'm also checking their hip range of motion a lot of times. They don't really realize I'm doing that. But yeah, I mean, you look amazing. So let's have you stand up. I'll just do a couple tests. The more involved things are done in the VFit department, and then they will come and talk to me like Zach does, and then I do my testing, and I don't recreate everything that they did, but what they do helps me make a decision as well. And if she's able to do her hop testing and her Y balance test and all the things that they say, then I know that that part of things is all set. But just a couple quick things I can do too, because a lot of orthopedic surgeons don't have a lot of time in the office. We take a lot more time than most people, but put your feet about shoulder width apart. So she does have a little, just in her feet, a little pes planus there, pronation, left greater than right. Now, show me a perfect squat. I'm sure you know how to do them at this point. All right, and you probably get a little bit lower there too, right? All right, so she's basically keeping her hip over her knee, over her ankle. she's not, when she's squatting, she's not going in like that. That would be a bad thing. We call that valgus. That puts a lot of stress on the ACL. So do it one more time. Excellent. So hip over near ankle. Now, on your right leg, do a one-legged squat. Okay, all right. Do it again. And have you been practicing those over there? You guys been doing that? Yeah. Try it on the left leg. I have a feeling she's going to be better on that one. Okay, so you're good. So bottom line, the only thing I'm seeing there is she's great on 2 legs. On 1 leg, there's still maybe a little bit of what we call dynamic valgus, which just means he's, like Zach said, you're still working on your hips. He's going to do more formal testing, but just that, to me, running a half marathon, I wouldn't worry as much about that. But getting back playing pickleball or basketball or volleyball where you're jumping and landing, you still need a little work in my mind. But I see all that, right? And so I would be like, she can run, she can cycle. I mean, even pickleball, you might be able to start getting back to doing some of that. But as far as like doing something like basketball or soccer or volleyball, I'd probably be a little bit still like slower on, okay? Just what I'm seeing here. Let's say you were perfect on that and everything checks out perfect when you're all warmed up, because you're not really warmed up right now, on when they do the testing on you next week. To me, the only other final piece is the MRI, which we don't normally get an MRI on people who have an ACL reconstruction, but the bear, we really want to see if that thing is growing back. And then we also want to see if it's matured. So we can, when ligaments are normal on an MRI or tendons, they're black. So we're looking for this thing to be black. If you recall, previously it was intact, but there's still some white or gray signal in it, which means it was still kind of pinkish or maturing. So we're gonna go look at it. We're gonna see it should look nice and taut, it should look black, it should look straight, and we'll go check it out. And to me, if it looks normal, that's gonna, if Zach tells me everything checks out, in my mind, you're good to go. If Zach tells me everything checks out and I think everything checks out, but that still looks a little bit in need of more remodeling or strengthening, because it takes time, it can take a year or 2, then I might actually be a little slower. If that looks great, but you don't do well with Zach, then you're still not cleared. See what I'm saying? So it's time, criteria, and we also use the MRI as another tool, not the end all be all.